Assalamualaikum and good morning, everybody. Uh, Alhamdulillah, we are today for another webinar by MYSIR. Good morning and thank you so much for joining us today. We have wonderful speakers, your seniors that are going to help with some basics of IR and some of it are your daily work as well. And we hope that it can help with your examinations or just part of your daily routine as future radiologists. Okay, so enjoy and savor the moments. Okay, don't worry about taking notes. Take a break from your usual study and just listen and absorb. And if you have any question, you can put it in the Q&A, or if you feel courageous enough, you can always raise your hands. And if there's an opportunity, we'll let you ask the question as well. All right. Today on the agenda, we have basic tools for embolization. You need to know some of the basic embolic material, catheters, what are the basic things that we do in interventional radiology, because it can come up in examination. It has come up for the past many years. And will be done by Dr. Farhan from UKM. And next, another bread and butter, you need to know how to do a nephrostomy and drainage. This is another popular OSPE question as well, drainage and nephrostomy, and the do's and don'ts. And this will be presented by Dr. Eric Chung from And we have our Sifu here of PTBD, Dr. Anis Shafina Mahfuz from UITM. And she will tell you all the A to Z of PTBD. So stay tuned for that. And Dr. Sim from HKL is going to teach you how to do a cerebral angio, the textbook, what you call the textbook version. And you may have some question and whether when you see other IR doing the cerebral angio, whether it should be part of your answers to the examiner. All right. We have another young trainee from USM, Dr. Nasibah Muhammad, that will sort of expose you to some OSCE questions. And then Dr. ID from UIA, some MCQ questions for you to ponder and to practice on. Dr. Hanani, our physicist from UKM, will do some physics quiz. And me and Prof. Izzah will give you some tips for part 1, just general advices and tips, so you'll be semangat for your exam in the coming November. I think so. All right. Okay. Okay. We'll start with the first one. Okay. All right. This is me. Okay. Enough about me. Okay. Next slide. Okay. This is Dr. Nick Farhan. Nick Fuad. He is a junior IR in my department, and I'll be happy to introduce him. And he'll be talking about basic embolization tools for IR. Okay, here we go.
All right, good morning. Assalamualaikum, everyone. Can you see my slide?
Yep.
Okay, so I'm going to talk basic IR tools and embolization. This is going to be quite a lengthy discussion, revision, but I hope I can keep it short and simple. hydrophilic, it must be wet, more glidy, and can pass tortuous area. It causes less resistance, but it gets sticky when dry. So always make sure the operator is not facing difficulty and pour some saline over the operator's hands to help them. This is the anatomy of a wire. It has a shaft, a core, and the distance between core and tip is also one of the property. And the core is lined by coil. The core or mandrel is lined by the coil, and the coil gives some behaviors such as radio opacity or even steerability. And outside of that, it's either coated with a hydrophilic coating or none, or other hydrophobic coatings. Okay. So not only we decide about diameter, we also talk about the core. It could be a stainless steel or nitinol. Stainless steel is more talkable and rigid and shapeable, but easily kinks, whereas nitinol is more flexible, but returns to normal shape after quite some time. In terms of core until tip or core short, so it gives more, the one with the short core gives more flexibility and shapeability of the tip. All right. The common wire types, so we have, I divided them into three: access wire, maneuver wire, and rail wire. So access wire usually comes with a sheath, the one that we use after puncture using a puncture needle to insert the sheath. So that's what I call as access wire. It's usually J-tip and hydrophobic. And then we use a maneuver wire, which is a glide wire. Usually it's hydrophilic and less stiff. We also have an option of a stiffer glide wire, for more support. And then rail wires such as unplug or even a J-tip, Teflon, which facilitate delivery of catheter or delivery of lines or exchange of catheter or balloon plastic. Okay, so hydrophilic O35, these are the two common ones. And then hydrophilic O18, P18 with a floppy tip. And then non-hydrophilic stiff wire O35, we have unplugs or even J-tip or supracore. So we use a torque device to better control and navigate. We can also use artery forceps if we don't have it. And then to manage your wire better, always use wet gauze to remove blood clot when removing the wire from catheter. And don't pull too fast, or else you cause vacuum in the catheter and the air will go in with a slurp sound. Okay, and you don't want that to happen. And then you loop them big. So if you loop it too small, it will spring into life from the basin. So and also it can cause kink or fracture. And when not in use, you let it loose in the basin or put them back in the casing and wet them. Okay, there are many catheters that we can use, but usually certain operators are familiar with their favorite catheters. Maknanya, although the options are there, but we usually use what we are used to. Okay, and the catheters can be used for diagnostic or therapeutic reasons, and it can maintain access into the cannulated vessel. So catheter is measured using French. So one French is 1/3 mm, and the catheter is measured using the outer diameter. And the choice depends on the anatomy that we are going to navigate. All right. And we have two different types of catheter groupings. One is non-selective and selective. Non-selective is like the pigtail flush catheter, where it is used in large vessels such as for iotogram or vena capogram, like a pigtail flush catheter, and it has many or multiple side holes. Whereas selective catheter usually has a single end hole, wide variety of shapes, and then this is one of the most common catheter, a cobra. So this is a C1, 2, and 3. The difference is the higher the number, the wider the loop. So this is the secondary loop. So this is a primary corner and a secondary angle. Okay. So the higher the number, the wider the loop here, and it causes a better support from the posterior aortic wall to cannulate the anterior vessel. Okay. Another popular catheter is SIM or sidewinder. Also the same like cobra, it has different sizes. The higher the number, the wider the loop and the longer the limbs. Okay. This is one of the way to form it in the aorta. So you advance it and then twist it clockwise and then push it down to form this seam loop, and then you pull it down in probably a helicopter maneuver. Next is also a common catheter use, burn or vert. Vert is just a more angulated version of burn and has a stiffer catheter tip. Okay, and it is quite direct, so a lot of people like to use this for neuro or lower limb work. Last but not least, Yashiro or Roche hepatic to use in celiac axis. So this is a Yashiro, which has a flat head here, whereas Roche hepatic looks down and then goes to cannulate anteriorly. Okay, usually used in hepatic angiogram to cannulate or hook into the celiac axis. And then the way to manage the catheter is always flush before and after use to remove the clot, and always advance a catheter over a wire, and don't bend or fold. Roll them like a wreath, macam kalung bunga tu, but not too tight or small to cause fracture to the catheter. Okay, next is sheath. It is color coded and the size measured in French, which is the internal diameter. So you can see this is the sheath, the outer cannula, and this is the introducer. So this is blunt, whereas this is sharp. So always advance a sheath with the introducer inside too. Okay, and this is the stopcock. So you point it towards the lumen that you don't want to, you want to block. Okay, so if I'm doing it like this, I cannot flush it into this side port. Okay, so turn it this way to flush it, and then put it in the introducer. We also have a longer version of sheath. Instead of the usual 11 centimeters length that we use in femoral access, we also have 23 centimeter bright tip, as for example, for nephrostomy work, also 45 or 90 centimeters catheter sheath for lower limb or even cerebral work. All right. Next is embolization. So it is a defining procedure in IR. We use it for hemorrhage, either iatrogenic or non-iatrogenic. Trauma, we can use it for pre-op embolization for blood loss control, and also for some other tumor embolization, such as STACE, uterine fibroid, BPH, or vascular tumor. And the principle is to occlude a blood vessel to reduce or obstruct the blood flow, as selective as possible to minimize the collateral damage to non-target structure. And vascular knowledge is very important. So let's say this is the gastroduodenal artery cascade. So you can see that the duodenum is supplied by the GDA, and but also comes a supply from the first branch of the SMA, which is the IPDA. So there's no use of coiling here to stop the bleeding here if you don't treat it here, coming from the back door. All right. And also, while doing the procedure, we also need to know the danger sign or warning sign, such as this spinal tumor angiogram, which shows a opacification of the anterior spinal artery. So, know when to stop. And then we also decide embolization based on the degree of permanence desired, whether it's temporary or permanent, and whether we want to occlude the large vessel, arterial or capillary bed. And usually, in general, to treat bleeding, we usually go as distal. But to embo a tumor, the whole circulation should be occluded, right? And in terms of safety, discard any saline or contrast or syringes that we suspect there's mixing with embolic agents. So this is very paramount in terms of embolization. So the key steps for safe embolization is good quality preliminary analysis, and then always think about collateral pathways, take the shortest, straightest approach, and then test the stability of the catheter before delivering the embolic material. And then use continuous fluoroscopy, and also monitor the flow, which will be obvious when using particles during injection or even placement of the coil. So, in general, we can divide types of embo materials to temporary and permanent, and they can be divided further into particulates, mechanical, and liquids. So, for temporary, we have particulates such as gel foam or ABC, Whereas for permanent, we have PVA, embolic spheres, or dry eluting particles. And mechanical permanent embo is coil and vascular plaque, whereas in terms of liquid permanent is glue, onyx alcohol, and sclerosins. So coils and plaques causes damage to the intima, causing release of thrombogenic agent. It also provides large thrombogenic surface. It is a type of mechanical occlusion to the lumen. Okay, so this is a fibered coil. And usually in the peripheral IR work, we use a fibered coil. And the diameter, when we see a number like this, 1876, it just means 6 mm diameter of the coil in a free, unrestrained area. 7 cm in terms of unrestrained length, whereas 18 means it can be used in an 018 system. Okay. Okay. So this is an example of sizing which can show the difference between the sizing, correct sizing. So this is a 3 mm coil which forms well in a lumbar artery, whereas not for a 4 mm coil. Okay. So in this diagram, it shows if it is too large of a coil, it doesn't form. If it is a correct size, it will form nicely to stop bleeding at the target. Whereas if it is a too small coil, it will float in the area of the target, and it can be pushed to non-targeted structure. And then in terms of coil delivery, for 035 coil, we can push using the standard guide wire. But in 018 coil, it needs a special coil pusher. So don't lose it because it's expensive compared to the guide wire. Okay. So when we use 018 coil, keep the coil pusher aside. And then once the coil is in the catheter, use the stiff end of the coil pusher to push it up inside. And then once it's about 30 cm in, you use the floppy tip to better control. There are also other types of coil delivery mechanism, such as mechanical release in the interlock or electrolytic detachment in this striker. Okay. And then next is unplugged vascular plug. It is a nitinol mesh which self-expands once we release it. So it is screw mounted and it is typically used in single high flow vessel. I will show you a picture later. Next up is particulate embolic agents. We have either temporary or permanent. So temporary like gel foam or ABC, permanent like PVA or DC beads. And these are usually used when there is multiple vessel blockage is desired, such as in tumor or in GI bleeding where there is no single vessel that can be cannulated to embo. So like a bleeding from the raw area, we use a gel foam or PVA. And then we should stop when there is slow to and fro flow. When we see the embolization under fluoroscopy, when there is yo-yoing of the material, we should stop and try to flush all the remaining embolic material within the catheter. Okay, not to have a preloaded catheter with the embolic material in. Okay, next is a gel foam. This is also a very common temporary embo material. We cut it into 1 × 1 mm pledgets, such as this, parallel, and then we cut perpendicular to it. And then in the bowl, you mix it with saline in contrast, or saline only if under ultrasound. And then to get the consistency of a pudding. So syringing in and out via a 3-way stopcock to get that consistency. And also there is also a method of using a torpedo where the length it is cut into a long strip and inserted into a syringe and then fired into a biopsy needle, coaxial needle, as for example. Okay. Then in terms of PVA, there are multiple range of sizes between 50 to 1000 micrometer. It causes thrombosis and fibrosis. And then one vial is usually mixed with saline and contrast. Personally, I use 20 cc saline and 20 cc contrast. And you can see this picture, it is well mixed here, but after a while it clumps or floats. So this is one of the disadvantage of PVA. And once you see this, the embolization won't be sufficient if we just inject the contrast fluid only without having a good suspension like in the earlier picture. So hence comes the embolic spheres. It causes it has ease of injection and less clogging, but we don't. It comes with a pre-filled syringe, and then we just aspirate contrast into the syringe, and no need for syringing in and out like PVA. Right? It can damage the particles if you use that. If you do to and fro syringing, it can be used in hypervascular tumors or uterine fibroid embo, as for example. Last but not least is glue. So it is a liquid embolic agent, also known as cyanoacrylate or histoacryl. It is non-resorbable, it's permanent. It polymerizes if in contact with ionic solution, such as blood or saline. So this is a very important point. So that's why we try to prolong the polymerization time and also make it radio opaque by mixing it with lipiodol. Okay, so the mixture with lipiodol depends on preference. Some people mix 1 to 3 and up to 2 to 5. And one vial like this is 0.5 cc. So if you want to make it 1 in 4, so 0.5 cc plus 1.5 cc of lipiodol to make it 1 in 0.5 in 2 cc in a 1 to 4 ratio. So preparation needs a separate table because we don't want to mix it with blood or saline in the old table, the first table. And always flush and wash the catheter lumen and hub rigorously with D5 to remove the ionic solution. And during the delivery, careful not to be too long, or else the catheter will stuck inside the blood vessel. Sometimes we can reuse the catheter, but not advisable. But we need to flush it with D5, although it will be sticky and has friction inside. We also have onyx, which is a liquid embolic agent. It is an EVOH copolymer dissolved in DMSO. So once this mixture is in contact with aqueous media like blood, the DMSO diffuses away. So the EVOH will precipitate and solidify like in this picture. Mainly used in neuro-IR. It is non-adhesive, so it doesn't have the same care like what we see in glue. Alcohol, we use for treatment of vascular malformation. Usually we give percutaneous. It can also be delivered intravascular. It can be combined with lipiodol in intravascular such as TACE. It causes cell death by dehydration and thrombosis and fibrosis. It causes permanent vascular occlusion. It is very painful and sedation and analgesia is required. Other sclerosants such as STS or polydocanol is also used mainly in venous diseases. Do I still have time?
Boleh lah.
Okay. A few cases lah. Okay. So post renal biopsy with flank pain and hypotension. So arterial phase shows this, and then renal angiogram, so contrast-embolization, and then we put a coil to stop the bleeding. Next up is post-PCNL, also hypotensive and flank pain. So pseudoaneurysm formation, and we glue to stop the bleeding. Next is upper GI bleed. The CT shows contrast extravasation in the duodenum. And then we can see from this, this is Yashiro into the common hepatic. And then this is the GDA, and this is the bleeding coming from the duodenum. Put a coil to stop it. And this is an example of a spinal tumor from a patient with a renal malignancy. So pre-op embolization. So we put in a lot of coil. We use a PVA and also some gel foam to stop the to reduce the tumor blush. Okay, you can see here tumor blush pre-embo and then post-embo. And we stop just before doing this embolization once we see the anterior spinal artery in another intercostal branch. Another GI bleed, which we glue You can see here contrast leak here, and then we cannulate using a seam and then a micro catheter, and then there's a contrast leakage here, glue delivered, and the bleeding stopped. And then one interesting case, this is the arterial phase in a CT abdomen, but what is peculiar here is the iso density of the vena cava in the arterial phase as isodense as an artery. So once it bifurcates into common eyelid artery, we can see that there is fistula between the right common eyelid artery and the left common eyelid vein. Aorta, common eyelid into the vena cava, common eyelid vein in the coronal picture. So in this high flow single vessel to occlude, we decide to use the MYSIR vascular plug. So coming from the brachial artery on top, this is the aorta, and this is the common eyelid artery that gives contrast into the vena cava to confirm the fistula. So we put a vascular plug, so there's no more leak into the through the common eyelid artery into the vena cava. That's all from me. Thank you.
Alright, thank you very much. Do you guys have any question dalam Q&A? Tak ada pun? Tadi Farhan tadi ada Bir tanya what is difference between glide and guide wire? If you can answer on your with your from your ni lah. I think basically kan they all selalu confused lah. Guide wire please, wire kan, everything lah. Kadang-kadang yeah. What's your comment on that?
Yeah, I think semuanya adalah guide wire. I mean, when we say guide wire, it's O35. I mean, understanding is O35 guide wire. But when we say glide wire, is the one that we want with the one with the hydrophilic coating, glide wire. So when I say guide wire, I might be referring to a J-tip Teflon covered guide wire O35 tu yang we usually use for delivery of catheter. In terms of when I'm cannulating into a vessel, arterial or vascular work, I commonly use a glide wire, which is the guide wire with a hydrophilic coating.
You have another question. When do we use Amplatz guide wire?
Oh, okay. When I use, so delivery of catheter or delivery of stent, such as ureteric stent or PTBD catheter. But the main point is Amplatz is stiff. Okay, Amplatz is stiff. So you use it as a rail wire to deliver structure. Even a catheter, even a long sheath. If I want to put a long sheath from the femoral to the carotid, I might use a Amplatz guide wire to put it there because I want to overcome the tortuosity of the aortic arch and into the brachiocephalic trunk. So it's for delivery of catheter or stent or device to get the stiffness. Okay.
Yeah, basically it's give support kan. And usually we exchange it after we manipulate it into a vessel supaya tak injured the vessel, and we use the Amplatz especially Amplatz kita guna untuk your perasan masa kita buat ureteric stent. We just want to straighten out all the curves tu, atas curve, bawah curve. So you want to straighten out, and you want to dah lah ada macam ada stone or stenosis, so you want to straighten things out. So Amplatz is very good. Dia akan straighten all the curves and give support to stiff devices, and especially in overcome stenosis kan. Alright, ni satu lagi. Type Kamarul Arif tanya, apa yang mempengaruhi embolic agent? Ada dua soalan. Lepas tu last kali, besides terumo and roadrunner, is conger also hydrophilic? I have never heard of conger.
Yeah, I also don't know conger. Apa yang mempengaruhi hydrophilic agent? Soalan yang
why do you,
luas apa maksudnya? Mungkin okay, apa yang mempengaruhi embolization choice kot? Maybe. So if I want, maybe if I want a temporary closure or permanent, if I want to deliver down distal or proximal, if I want to have wider coverage of supply, I'll use a particle. If I want to be specific to a vessel, I'll use a coil. Other than that, if I'm left with if I don't want to waste a micro catheter, I will avoid glue. So maknanya apa yang pengaruhi itu maybe the decision of the choice is depends on a lot of factors lah, such as I mentioned. But in terms of apa yang mempengaruhi emboli effect, apa yang membuatkan satu tu emboli is like I mentioned lah. So mechanical occlusion, damage to the vessel wall, damage to the formation of thrombus, and also which needs good coagulation profile lah for the patient.
That's jawapan dia mungkin untuk part 1, you need to know apa yang temporary, apa yang permanent. That's one. Selalunya and then what type also dipengaruhi oleh whether you can cannulate distally or proximally, and whether so cannulation also but that is another level. You just have to know that permanent is glue, coil, PVA, they all are permanent. And then I think some old MCQs akan cakap autologous blood clot, but rarely lah we use lah autologous blood clot. Okay. Alright, ni I think somebody also tanya pasal Conga tu. Conga tu there's a lot of brands tau. The classical brand is the Rumo yang ada kan, hydrophilic kan. But different company. Roadrunner pun very, so yang masuk wire, yang masuk artery ni usually very glidey, very smooth and very slippery. That's it. Habis kan? Alright ni, good morning Prof Yasmin and Dr. Farhan. Is a J-shaped tip wire less likely to cause clot formation? Why is the wire J-tipped? Whether you can answer that? Yeah.
Okay. So I think the question ni macam is the question comparing with another wire. I
think dia tanya whether the tip. What's the
wire? In my opinion, the question is about the wire itself lah. So J-tip wire is usually the one with Teflon. So it is the hydrophobic coating. It is not meant to be used. I mean, it can be used in wet and dry conditions. It has good steerability and stiff, but it has no hydrophilic coating lah, such as a glide wire. If I'm comparing J-shaped tip wire compared to a hydrophilic, I'll say yes, it causes it is more likely to cause clot formation lah compared to a hydrophilic wire.
So kalau soalan dia mengenai the tip of the J tu is to reduce trauma, to prevent trauma to the vessel. Okay? So you don't let cucuk straight away. Okay, we are